Hannah, yeah, you have as you explain it, it seems all very easy. But we know, of course, it's not that easy at all. So I have been wondering, for instance, do you have a preference for using EUS or MRCP, or do you always do both in these kind of patients with suspected stricture?
It depends a bit on the location, of course. For extrahepatic, you can use both, I think, but because it's very difficult often, we usually use both.
Okay, you always use both. Everybody agrees here? The other interventional endoscopists?
Yep.
Okay. Okay. You also, so sometimes if you have a pancreatic cancer who is operable, but it has to be delayed, so we put a stent. You always put a covered stent, or you sometimes put an uncovered stent, or always a covered stent?
I always put a stent that can be removed. Can be plastic or fully covered, but
yeah.
I think it's really a mistake to put in an uncovered stent if it might be resectable.
Yeah, if your patient needs an operation. Okay. If there are other questions from the colleagues?
Yes. About the diagnosis of strictures, do you, we have spyglass of course, but do you also use intraductal ultrasound from time to time, or?
For the time being, we don't. We only use EUS and cholangioscopy.
Okay.
I have a question, Hannah. Do you have any experience with fully covered metallic stents for benign pancreatic strictures? Because I have the impression that there are more and more papers showing that this could maybe replace multiple plastic stenting.
Yeah, actually, we don't use it. We use multiple plastic stenting. Although the data are there, I agree. We always have the. We're a bit scared that you close side branches, and although the data are not supporting, for us it holds us back from placing them.
I hear you. I don't see you, but that's okay.
Hello,
okay, that's
hello,
you.
Danny.
All right.
Okay.
Good morning, everyone. So this is. I don't know if we have Laura who will present the case first.
Yeah.
Okay, so this is a 6-year-old patient with recurrent acute necrotizing pancreatitis complicated with third infection of Waldorf necrosis. This was successfully treated by temporary LAMPS placement and necrosectomy. The control MRCP shows now a probable benign stricture in the main pancreatic duct of the head of the pancreas with dilation of the distal main pancreatic duct. So on the next slide, you can see the MRCP image. Today we do the ERCP for stenting of the benign stricture.
Okay, the endoscopist is Christophe Snouwaert, who's working as a interventional endoscopist in Brugge, Belgium, and also in Brussels. And I don't know who he is accompanied with.
With the lovely Helena de Grote,
okay.
Larissa, and Jolien.
Okay, great. Christophe.
Okay. So we had this patient had the biliary pancreatitis, but we now have like an accidental finding. There was a problem, or we suspected a problem of pancreatic duct stricture, which is perhaps the case, but you can see here clearly now that he has a common bile duct stone just in front of the papilla.
Yeah, it was not seen on the MRCP, but now on
it's not seen on the MRCP,
it's
that's
clear.
true. And it's also a nice demonstration. Can you put on the Doppler?
Yes.
That echoendoscopic ultrasound is much more sensitive for small stones than MRCP, because you see here the caliber of the common bile duct is very thin. Just try to show you the pancreatic parenchyma in the corpus.
Yes.
I think it's here. Now, Helena will try to show you the duct. It's rather small here, the diameter. She's trying to follow it.
Up?
Yeah,
Yes,
there. The small. So you see the transverse section of the pancreatic duct here. I think if we measure it, it will be like 2 millimeters. So perhaps the pain that he has is due to the common bile duct stones and not due to a pancreatic duct problem.
Yeah.
Okay.
Besides the fact, Christophe, that we have a solution, probably a solution for his pain problem, But what would be in a patient who is asymptomatic and who has a pancreatic stricture? Is it an indication for stenting?
No. Asymptomatic patients never need pancreatic therapy, I think, because the risk of complications in doing that is too big.
Yeah.
Only treat symptomatic strictures.
There are no data supporting that stenting would prevent development of exocrine pancreas insufficiency or diabetes even?
I think Pierre Dupré has published some data regarding that, but that perhaps there's a small benefit for regarding the endocrine insufficiency and exocrine insufficiency, but I think there's not enough data to support to treat every patient with the stricture.
Yes. Yes, and now you see it clearly. Yes, it's again pushing myself out of the stricture, so you can deflate again. And I'll try to stay in the right position now. Now I know that I have to push a little bit to remain in the same position here. Yes, go ahead. Yes, and now you see that it's just behind my endoscope. You see the nice impression on the balloon. And so this will definitely be sufficient to place a metallic stent. So now the question is, what size will we use? You can deflate. So most of the time, if you place a metallic stent, it will always be longer than you expect. And 10 centimeters in general will cross the hilus. So here there would be not a big issue with crossing the hilus because I would drain both sides, even though my stent would end, for example, in the left hepatic duct or in the right hepatic duct. But to allow easy future procedures, if necessary, I would like to make a dent just below the hilus, so that I have still easy access to the left and the right side intrahepatic bile ducts. So if we expect that a 10 centimeter stent would end in the intrahepatic bile duct or in one of the hepatic bile ducts, I would go maybe for an 8. What do you think, Helena?
Yes, I agree.
Helena agrees. So yes, so this means there's no need for brushing here, because we know the diagnosis, of course. And we will place now directly this uncovered biliary metal stent of 8 centimeters.
While we are having a look how Peter is going to place the stent of 8 centimeters, because he estimates that's the distance he needs, I'm going to ask to Hanne van Malenstein if she also estimates what the length should be, or do you measure your length?
We also estimate. It's experience, of course, but you can estimate the length quite good if you have some experience with ERCP. And I agree here with the 8 centimeter length of the stent.
So 8 centimeter is a stent for beneath the hilus.
Well, you always have to look at your pictures and your fluoroscopy, but here I think this will, and I agree with Peter to place the stent below the hilum.
Okay, and so do you use the vertebra, for instance, to say that's 2 centimeters? Or how do you estimate this?
Well, we know the thickness of our scope, and we know the length of our dilatation balloon, for example. So these are some tricks that you can use to better estimate.
Okay. Okay, in the meanwhile, the stent is going up.
Maybe the image. The aim is to end really here below the hilus. Yes, so okay. So you see that it's longer than we expected. So this is always the case. But I have my yellow marker here, and from the
The proximal part of the stent is now in my desired position. Okay. So I will now try to remain in this position here while Larissa is opening the stent. So I'm retracting now while Larissa is slowly opening the stent.